No, so you guys are all good. Kids are spoiled. All right, so good. Now that we're all here, I can see me too. We are going to go ahead and get started. So let's go around the room. I'm looking at you all from left to right. I see Michelle on top, Evan, Dan, Con, Jeff, Trent, Nicole. Let's go ahead and get started. Just introductions. Michelle, why don't you start? Kind of give a sense of when you graduated, your fellowship, and what practice you're in.
Okay, so I graduated, I think Trent graduated in 21. And I went to fellowship of sports HSS, and I'm now at HSS, the NYP location at Weill Cornell.
Evan, how about you?
I graduated in 2019. I did fellowship at Emory in sports, and I'm now in just south of Birmingham, Alabama.
And what's just what practice you're in? Is it private practice, private academic? Is it a academic practice?
Yeah, I'm in private practice.
All right. How about you, Dan?
Graduated in 2019 with Evan and Hakan. I went to Duke for a hand fellowship, and then I settled back in Michigan, in Grand Rapids, at Corewell Health / Michigan State, sort of a private academic model, if you will.
And Hakan?
Also graduated in 2019, and I went to San Diego for fellowship, and I'm in a private practice that's like private academic where I work with some residents, but mostly kind of doing my own thing in private practice.
Good.
I graduated in 2021 with Michelle too, but really graduated with Night Float and Dan. So good. I work in Pittsburgh. I went to fellowship at Pittsburgh too for hand and upper extremity, and then stayed at UPMC, and I'm technically a UPMC employee in their kind of community division.
Jeff, let's give it over to you. How about you? All right.
Yeah, Jeff Boatright, graduated residency in 2017, and then stayed at UVA, did my hand and upper extremity fellowship there as well, 2018. Been in private practice here in Mobile, Alabama ever since.
Well, in fact, about Jeff, when he was a busy medical student, he actually didn't even get an apartment, just lived in the call room the entire time. So
That's true. That's true.
That's true. Nicole.
So I guess I was 2022. I'm the youngest of the group, still slogging through my first year. But I did a fellowship in total joints out in Denver, and I'm in Raleigh now in private practice.
Aaron Casp.
Yeah, I graduated in 2020, did a sports fellowship in Vail, and then I am in pure academic practice at in Birmingham, Alabama, at University of Alabama-Birmingham.
Great. So it's a group. I think we might have Ahmad might join us a little bit, and so Beamer. So we'll see you all. I appreciate you all being here. It's the Alumni panel. We have our residents sitting in front of you. Hopefully you can see the entire group. We have some fellows in the back, and some medical students as well, from the faculty here. But we really anticipate a huge you guys come back to talk with us, because I think that everybody in the room sitting here doesn't realize how fast it goes. I mean, I feel like it was just like last year that all you all were sitting here in this conference room as residents, and then it goes really fast. So I have a couple of questions. Bobby, you have a question you want to ask while you're right here?
No, welcome guys. Thank you for doing this.
Okay, good. So you can hear everybody okay? Our room? So just to give you a sense of who's in front of you, you've got interns in the front, PGY2s in the second row, the 3s are in the third row, the 4s and the 5s, and the shells behind you. So that's kind of who all there is. You guys recognize the faces of the crowd. Hopefully, maybe the guys in the back row, you might recognize some of them. But this every year it turns over and over. So I'll start just kind of go through each one of you. I think the first question I think a lot of people have is, how did you get your job? So Evan, how did you find your job? And how did you look for it?
Yeah, I mean, this is a always a varying process for everybody, I think, that goes through it. Mine was actually the president of our group ended up reaching out and somehow found that I'd be looking for a job possibly down in Alabama. So that was just dumb luck. I mean, he literally called me chief year around October and was just like introducing himself. And from there, you know, that was knowing that was a pure private job. I still wanted to look around a little bit. So some of it was cold calling, some of it was seeing what was available out there. Some of it was talking through, you know, mentors at UVA about people who maybe knew what jobs might be available. And again, it's, you know, I don't think it's ever too early to start that process. Maybe your intern year, I wouldn't start looking because things are going to change. But once you have an idea of what you're going to be doing and kind of an idea of where you'd like to be, I think it's worth start seeing what's out there.
How about you, Trent? How do you job? You have a job?
Yeah. No, I'm doing just a little weekend work. Yeah, I had the good fortune of having my father's an orthopedic surgeon with UPMC. So reached out to his group too. And, that's how I got my job. So I'm in practice at the big group under the UPMC umbrella, but a little bit different.
Nicole, so you're in your first year of practice right now. Like, can you kind of give a sense of like what your first 6 months, 8 months has been like?
A roller coaster. I'm sure everyone who is here can attest that the first year has been every day is a learning experience. I think everyone tells you how tough it's going to be, and that you're not going to sleep well, that you're going to, just think about every single case before it happens, after it happens, what could you change? At least if you're, I think, a thoughtful surgeon, which I'm sure everyone in that room is, it is much harder than I ever expected it to be. And a lot for many reasons that I don't think I truly understood, especially being in joints. All of my cases are inpatient. Having an assistant in the room actually matters. Having an assistant that doesn't break the femur when they're reducing a posterior hip also matters, which happened to me a few weeks ago. Doing on cases and very sick patients that are in their 80s, 90s, starting cases at 5 and 6 p.m. with unreliable help in the OR, all the things that you take for granted being a resident in an academic facility, always having extra hands available, having staff that know what they're doing, and someone else there to back you up, are things that I didn't realize were going to be such a challenge. I do think it's somewhat unique to things like trauma, spine, joints, where you're doing a lot of inpatient heavy work, and probably private practice more so than academics, but it has been, every single case has been a learning experience, despite being 8 or 9 months in. It is still, I feel like there are days that I feel like I'm reinventing the wheel over and over again. So it's been good. I do feel like I'm significantly more comfortable and better at handling situations in the operating room than I was 6 months ago, but it is tougher than I ever expected it to be.
So, Boatright, you're probably the I think the elderman of the group. Does it get any easier?
It does. I would echo everything that you just said, and that some of those things never go away. I think if they do, I think if some of your worries and your concerns about your patients and the learning that you experience doing cases, if that ever stops, you're probably done. But it does get easier. You do spend less time worrying about things as time goes on, and you do become more comfortable, and you do figure out all these little things about how to make all these intricacies work, these things you don't think about in residency. Just like anything, the more you do it, the more you figure out your system, the more you figure out how those things work within whatever system you're working in. And the more time you get to actually, spend thinking about and doing the things that you actually like doing, like surgery and taking care of patients and not worrying about all those other things. So it does get easier, but that never goes away.
So Dan and Hakan, you guys are both in pretty subspecialized practices, correct? You guys just do hand and just do peds, or do you guys do general stuff as well?
Yeah, I just do hand.
Yeah, and do you just do peds, Hakan?
Yeah, I 18 and under for me.
So do you guys have any, so that's kind of a, you know, compared to like the general practice some of y'all might have, do you guys have the opportunity to do any general call stuff at all, or are you guys just doing your own specialties?
I just take peds call where I work. And generally the ER, after a few years of working with them, they know exactly like if it's a 21-year-old with something that they won't call me about it. Occasionally they'll rather call me just to get advice than the adult guy because they don't like the adult guy on call. But generally 18 and under, I'll see and manage, which has been good for me.
Don't you work in a freestanding children's hospital pretty much?
He might not be able to hear you. I muted. So
No, I heard him. I heard him. No, right now I work at 2 hospitals. One's a level 1 academic hospital with a med school and the ortho residency. And I do that probably like 3 times a month. But then there's a level 3 hospital that has a peds ER and peds ER attendings. So it's a pretty big hospital. And that's where I take a majority of my call at.
How about you, Dan?
I just take hand call, which is plenty busy. Here we cover multiple hospitals and then innumerable urgent cares and other like outside facilities that our system owns too. So I just take hand call. I've never heard of anyone actually doing hand and general where I practice.
So Aaron and Michelle, you guys are both academic sports people. Do you guys do any general stuff?
Yeah, I work at a couple hospitals within the same university system. So the sort of outpatient hospital where I do most of my surgery, it's called Highlands. We take like 1 week straight out of 6. It's usually pretty low acuity stuff or PJIs that get passed off. And then I do probably 1 to 2 days a month at UAB Maine. Usually on the weekends, and that is very busy. It's always a little tricky to have there's no follow-up trauma here. You break it, you buy it, basically. So I have, broken hip fractures and open tibias that follow up in my sports clinic, which is always interesting.
How about you, Michelle?
Yeah, I also take general trauma call a couple times, like 5 or 6 times a month during the week, and then 1 weekend every 6 or 7, depending on how the rotation goes. We do have residents here, so that helps obviously offload me going to see consults. But similar to Aaron, I have my post-ops follow up with me. And another thing, not everything is as subdivided as UVA. So joints doesn't do the hemis, I do the hemis, I do the both bones, we do everything. And so making sure that you not only know your bread and butter trauma, but also trauma that's subdivided at your residency institution, or kind of different ways that people divide things. I remember how to do a hemi. I have to do laterals and hemis in people who have dementia. So things that you kind of take for granted, the joints fellows might do it. Make sure that you remember all varieties of trauma, because your job might require you to do all different kinds of things that you might not have kind of really gotten when you think of general trauma. Things like hemis, upper extremity, lower extremity. I pinned a talus last week. Things that you really didn't expect you do in your subspecialty sport practice.
Yeah, that's a good point. Show of hands, how many of y'all are doing arthroplasty in your practice? Evan, you are, yeah. See, how about you, Trent? Nothing? No arthroplasty? Dan? Oh, wrist arthroplasty.
Yes, elbow. Finger.
So, Aaron, Evan's in your community. How often is he dumping things on you as the academic guy?
Evan is actually the least offender of everybody in the area, to be honest with you. No, seriously, he's got really good training. I've told people his name, and some of the guys here are like, "Oh, I haven't seen any trash from him." So, like, honestly, there's a lot of people that dump on the institution. Evan has good training, and he keeps a lot of his garbage.
All right, guys. Ahmad Fashandi just entered the chat. Ahmad, can you introduce yourself and tell us when you graduated and where you are now?
Good morning. Can you hear me? Okay.
Yeah, you sound great.
Perfect.
Ahmad Fashandi, graduated 2018, currently in Richmond, Virginia, working at Chippenham Orthopedics, which is a level 1 trauma center, community trauma center. Been with this group specifically since the beginning of the year, but at this hospital, at this facility for 2.5, almost 3 years now.
Cool. You guys live in Richmond? You guys?
We do. You might, because you see my wife coming to Charlottesville all
I
the
see
time.
your wife. I see your wife like maybe once every 2 weeks. So I was just curious where you guys actually lived. I live in Charlottesville, and she drives to Richmond.
Yeah, we live on the west side of Richmond, so she's about 45 minutes, 50 minutes from getting to Charlottesville. So it's not terrible. She only comes 2-3 days a week to the hospital.
That's perfect. That's perfect. All right. So here's a question from the group. I thought, let's say, how about you, Nicole, since your first year? Like, what's the most helpful resource you've had in your early practice? Was it a department, the mentor, a family member, a podcast, a financial planner, anything? Most helpful resource you've had?
I would probably say my either co-residents or co-fellows. There have been a few pretty low points, especially in those first few months of practice. Some things that happened to patients out of my control, but they were still my patients. And having the ability to call up Michelle and be like, I have no idea what is happening. I don't know how to handle this situation. I don't know how to get what I need in the operating room, or have people, help me, help them. And so being able to call Michelle to talk about cases with my co-fellow, I talk to him nearly every other day. I still talk to Emmanuel regularly about cases. And I think truly being able to lean on your co-residents, your co-fellows, because especially the first year, but even the first few months of practice, it's very isolating, and you feel totally alone in the operating room where no one else, it seems, knows what's going on. And so I think having other people to lean on is an incredible resource.
How about you, Evan? Good resource for you.
I think a lot of it is you need to trust your training. I think it's easy to start getting overwhelmed by all the bad stuff that happens. And like Nicole said, I mean, it will happen. And a lot of times it is out of your control. I've found most of the group that comes out of this program is very conscientious about what they're doing. They're very thoughtful about what they're doing. And that matters. I mean, I think it's, like Aaron said, these final stopping grounds, these level 1 trauma centers are the ones who end up seeing a lot of the outside hospital referrals. And, for better or for worse, your name gets out there. And if you decide you're going to send a lot of stuff just for whatever reason, that gets known. And I think that from my standpoint, you go back to your training, you go back to how your mentors did it, how folks that you worked with in residency and fellowship did it. And then from there, not everyone has the same kind of access to different, for my hospital, for instance, like we don't have anything on the shelves when it comes to revision, anything. So you got to think ahead a little bit and make sure that you kind of know what you need ahead of time. Because you can really get into a bad situation where if you think, well, I've got plan A, B, and C, but you don't tell anybody what plan A, B, and C is, next thing you know, your reps, flying down Interstate 65 to try and go and snag some implant off the shelf at their center that might be 45 minutes away.
Michelle, what's been the biggest kind of surprise getting in your practice starting? Like, what was like something you didn't expect that you find either in the clinic or in the operating room?
I think you kind of expect it to be like residency. Everyone knows what the case is. Everyone knows what instruments you need, what implants. Your attending makes it look super slick. Same in fellowship, everything goes well. And then you get into practice and you have staff who's never done an ACL before. They don't know what a reamer is. They don't know what a graft table is, or people who the reps try and help with the things aren't organized or things aren't clean. And so you have to really, I think a lot of it is on you and being prepared. And so we learn on residency, you're on call, you have your list of things you have to do. And so I think translating that to an attending, making preference cards, I found really helpful. I had a case, you sat down and you say from start to finish, what do I need from pre-op to setup to draping to prep, everything. And so that helps you be organized, and it helps you before you start a case, go to the scrub and say, do you have this instrument? Do you have this? Do you have this? Do you have this? In the middle of the case, you're not scrambling and you realize that your surgery center doesn't stock this, or they didn't clean that tray or something. And so making sure that you're organized, I think, is really helpful. But I mean, things have happened. I've had to ship a flexible pin in an Uber from the implant facility because they didn't order any. And so making sure that you can figure things out or use a different reamer system or something you're comfortable with, which we get well trained in having plans A through Z, but that really needs to happen in training that you translate to being an attending, because when you start, it's not going to be as easy or streamlined as you've seen. So just, I think that was something that I think I was told, but you don't really know what to expect until you see it. And you're like, oh, they really have no idea. They've never done this case before. How are we going to get through this? And then you figure out ways to make sure that things are organized and that you have what you need to do your case.
How about you, Dan? Anything? Dan Hess, what's been a surprise to you as you got your practice started?
Yeah, I think just sort of, especially right away, it's just the decision fatigue that really sets in. It's all of a sudden you're just trying to get started. You're trying to do what you know, and then all of a sudden you get asked a million questions you've never thought of before in your life. So it's all of the like the stuff that Michelle mentioned, the pick cards, but then it's all like your post-op recovery. When do you want to see these patients back? When do you want to like, do you want to see hand therapy? What kind of splint do you want them in? Like, just an incredible number of decisions while you're already stressed and just trying to figure out the simple stuff. So all the more reason while you're in training to pay attention to the small stuff, pay attention to when patients return, when are they sending them to therapy, start making some lists of some common procedures and exactly like every single step of the way, know how your attendings do it because they've already figured it out. And then the other two things I would mention from the previous question about resources, one can be the reps. I mean, you got to be a little bit careful with like relying upon reps too much, but they can be a really good resource when you're trying to figure out like, okay, what should I do for this particular case? You know, especially if you have a little bit of advanced notice. If you know you want to use a particular implant, but you're not sure exactly how you're gonna do it, you know, they can even, I've had a couple of times where I've had them just like get a cadaver arm in. I try some things on for cadaver arm a week before my surgery or the weekend before. So they can be a really good resource in that way, as long as you don't, lean on them too much or, in an irresponsible way. And then the other one would be your partners too. I think that's a really underrated thing. I think that not everyone can control and not everyone, I guess, likes their partners, but that's, I mean, to have good partners and people you can sort of bounce ideas off of and to support you emotionally and in practice, I mean, that's incredibly valuable, especially when you're first just getting started out. So it's a hard thing to learn when you're trying to figure out what the job is, but, definitely try to figure out if you like the other people in your practice. It'll make your life a lot easier.
Just so you know, we have two of your former resident colleagues in the room now, Mike Hadid and Max Hager in the back of the room. And then also in the virtual space, we've got Dr. Quay, we got Dr. Brown, Dr. Werner, we have everybody, Dr. Romness, so we have a lot of people who've joined in. So I just want to say thank you everybody for joining us virtually. So I want to go around the room actually real quick and just ask you, who is your first assist in the operating room? So I'm going to start actually with you, Ahmad. Do you have a PA or a resident or a fellow with you, or is it who is your helper in the operating room?
We have a collection of PAs. They are often in with us for our trauma room days, not for our elective room days. And then elective room days, there are surgical assistants from the hospital.
So do you find you have good help, it would seem? Because that's one thing I always hear from alumni is that sometimes the help's not quite as robust as it might have been during residency.
Yeah, I think that's different. Good or bad, it varies quite a bit. I think the PAs, the ones that are more tenured, you can teach them and they learn your routines and they're, it's great. They're helpful. But I think that one of the things that became obvious pretty quickly is you're doing everything, you're doing all the important steps, and you got to figure out how to do those effectively. Like, you don't ever expect to have particularly effective helping hands. And so once you get it, and it kind of doesn't matter who's there helping. When you have a good one, it's a bonus. When you don't, you're still doing it.
How about you, Nicole? Who's helping you off your cases?
Somebody different all the time. Sometimes I get some of my partners, my joints partners, PAs. That's really helpful because they actually know how to drive a leg when I'm doing a posterior approach. Sometimes I get a scrub tech who is senior, and I actually really like when I have some of the more experienced ortho scrub techs that do a lot of joints because they are incredibly helpful. That is kind of few and far between. Sometimes I get a scrub tech who doesn't even do ortho. And I gotta say, it's really hard doing a periprosthetic proximal femur fracture with the person on the other side of the bed that's never reduced a hip. So it challenges that you don't think about. And it does make some of the more complex cases even more complex because the person across the table may or may not know what they're doing.
How about you, Aaron?
Being pure academic, I have a resident. We're a mentorship model, so I always have the PGY2, which is always a tricky balance, and that was something that was difficult coming in, like letting them do certain things, how to teach, how much to give up, how much can you trust them. I will say I have this fracture Friday kind of thing, basically. So my clinic is just one floor up from the ORs. So I can add on fractures on Friday, like clavicles, proximal humeruses, with both bones, whatever, ankles. And the PGY5 on sports, if I have a good one, I just sort of let them run their own mini trauma room because this is still very old South. It's probably the only place in the country where residents can time out and start their own cases still. So if I have a good PGY5, I can just let them run and I'll poke my head in and they'll show me some final fluoros and just let them go. That's been an evolving process, and it really depends on the level and skill of the resident. And that has probably been the most surprising thing too. As a resident, you're just kind of slogging through it. You're really focused on what you're doing. You may operate with some of your upper levels, but you very rarely see like the entire breadth and scope of residents. And I would say how different all the residents are has been very eye-opening to have to adjust teaching styles, and you finally get a resident that gets what's going on at the end of the block, and then you start over with a brand new, like early in the year, especially this next block I'm not looking forward to. I've got very senior PGY2s right now. Next thing I know, I've got like a super intern starting on sports in my sort of, and that's in the summer. That's complex injuries. Football's huge here, so that starts when I get a ton of ACLs. That's when I get a bunch of the UAB athletes coming in, and I've got revision ACL add-ons on Monday afternoon starting at 4 p.m. So that's always a little tricky.
So to be honest, UVA resident, UAB resident, obviously PGY2 UVA would be a lot more skilled, I would imagine, right?
Yeah, I would definitely say the quality of resident varies across institution. So that's all I'll say.
In case you're wondering why Bobby's up here, he's taking a role just like the old days. Who we got? Trent, how about you? Who's helping you out in the operating room, Trent?
So I have a PA too, but yeah, I mean, as it's been echoed too, you'll have different scrub techs. I rarely have the same kind of other support staff. So my PA is my one consistency. So he's with me in the operating room. Also, he has kind of a parallel clinic to mine as well, which is nice. And then on the weekend, we'll have whoever is on call with our PAs in the group too. So the help can vary. I handle general call as well on like the weekends too. So sometimes you get a PA that does joints and is very good and very helpful, but sometimes you get someone that's not as exposed to that subspecialty too. So you got to be prepared kind of at all times too. But definitely having some consistency at help is a huge boon early on. But you're still trying to figure out also what you're doing too. And then if your PA is relatively young like mine is too, you like Ahmad said, you kind of have to coach them and let them know how you want stuff done too. So it's a lot of decision making, instruction, and everything too that adds just multiple layers onto every case that you're not exactly expecting to, and it can wear on you.
Jeff, we're gonna switch up a little bit. Who's helping you out in clinic? Do you have a PA in clinic with you, a scribe? Do you write your own notes? Do you make your own PowerPoints? For how much you like PowerPoints back at UVA?
Yeah, so in terms of clinic, it's just me and an MA. There's really, no help. I she'll start my notes, I'll finish dictating them. We have a pretty user-friendly EMR, which obviously helps. And but it's really just me. In terms of the operating room, it varies. We own a surgery center, and as a hand and upper extremity surgeon, that's where I do the vast majority of my cases. And so it's normally just a scrub tech, but an experienced one. We have a few PAs that kind of float around and belong to the group. And so for this bigger, when I'm on general call and bigger trauma cases, I'll have typically one of them help me. I intermittently have a resident. We have an orthopedic. The University of South Alabama has an orthopedic residency, and they don't have a full-time hand surgeon, and so they'll come and spend some time with me, but that's kind of hit or miss.
How about you, Hakan? Who's helping you out in the clinic? Are you writing notes? You have a scribe?
It's just a PA that I hired when I started. Same PA, fortunately, she's awesome. And so she'll either have her own clinic running at the same time as I am, and so I can double my patient volume, and she'll write her notes, I'll write mine. If she is not seeing patients, then she's just kind of scribing and kind of getting PT orders and stuff like that, scheduling surgeries for me. So she kind of bounces back and forth seamlessly, which has been great. She also helps me in the OR and on call, and it's been awesome watching her learn. And I'd say from an orthopedic standpoint, she has tremendous skill for a PA because she's been doing it for years now, and that's all she's done. So she'll go and do simple reductions. She's preparing ACL grafts for me in surgeries, holding reduction. So it's been awesome having her. She's really into ortho, and so that's been awesome for my practice.
How do you say you hired the PAs? Does it come out of your overhead, or who pays your PA's salary?
Yeah, it's purely from my collections. I have an incentivized kind of contract for her where she has a base pay, and then the more work she does on her own that she can bill for, she gets to keep that. And so she's highly motivated to make a lot of money. It's expensive living in New Jersey. So, she always wants to take calls. She always wants to go into the ER and do surgeries, and just kind of, she works hard, and it shows. So it's been good for me because I get to, keep the collection she makes a part of it. And so it works out for both of us.
How about Dan? Dan, what's your team like?
So I have a PA that's mostly with me in the ORs. One day a week I'll have a resident with me. It's a PGY4 resident. The other days it'll be the PA. And then on call I'll have residents, although like that, surprisingly, to cover call cases, a lot of times I'm just doing them by myself. So it's a bit of a mix. I have a scribe in clinic that I actually pay for. I just hate writing notes so much. It's worth it to me. Yeah, I would definitely echo, especially what Aaron said about working with residents. That's a whole different ballgame that I really appreciate all the stuff you guys did. It makes you realize how hard it is to do it on our side. And I'll encourage you, if it's possible, if you are going to join I don't know if Aaron had this opportunity, but if you are going to join a practice that has residents, maybe like not working with the residents like for the first 6 months or a year or something like that, just to kind of get used to things so you don't have the pressure of handing over the knife right away. I didn't work really with the resident other than call for the first year. I'm in my 4th year now, and then you kind of like, I don't know, you figure yourself out a little bit, and you figure out your place in the residency, and you can become a faculty, and just you can offer more at that point in time. But I'll say PGY2 would be tough. I think PGY4 is also a hard sort of level to teach. I think they're all kind of hard because you're trying to give them the best experience, but you're also trying to take care of patients. It's a tough balance.
Yeah, so I mean, especially your first year, you're also doing your board stuff, and you know it's hard. Documentation is important your first 2 years, your ABOS part 2 and stuff like that. Are all who all has boards left? Ahmad, you're through. Aaron, you're through. Yeah. Is anybody doing them in July this year? You are, Michelle.
Yeah,
Michelle
Scott and I are.
Yeah.
A lot of fun. We're here for you if you want to go through in your cases with you. Evan, what's your team made of?
I've got a PA that I got hired after my first year, and again, we won't get into the business stuff too much, but a lot of times the guaranteed salaries like I had to bring service to an area of need is kind of how they roll that. You can't hire a PA on that guarantee. So my first year I was by myself. And then from then on, I hired a PA who's been excellent. He does everything in the OR with me, takes a general call with me, and in clinic when I'm there, he's usually he sees we set up an osteoporosis clinic that he'll run as well. But then with me, he'll end up scribing most of the time. But I'll dictate pretty much all the notes. He'll just get all the orders in while we're in the room, and then like Dan said, I loathe the dictation, but it is a very important aspect from many facets of medical legal documentation. But yeah, so just Andrew and myself, but it's nice having some consistency, because again, you never know who you're going to get in the OR at our surgery center or at the hospital.
How about you, Michelle?
So initially it was just me in clinic, just doing notes and kind of doing everything in the OR at my outpatient days. There was core PAs that kind of floated through, and so they had varying levels of comfort or understanding of cases. On when I cover the trauma room or when I cover weekend call, residents are there, and I would echo what Aaron and Dan have said about working with residents. I think in your residency, you know what a UVA PGY2 should know, what a UVA PGY4 should know, but at a different institution, there's different training, and I will say the caliber is very different, and kind of really understanding what they know and what they understand. And then again, when you're the chief, you know that PGY2 is strong, that one you might need to watch on this part of the case, but really understanding which resident is strong in which cases and what you should let them do. I've had incisions that are we have to tell them to do it again, kind of in a different location, because you assume that at this level resident they would know, kind of thing. So being really careful that at the beginning be really overly involved. I think that's something as a new attending, like Dan said, I work with residents on the weekends, and so again, I was super involved. Like I did the whole case. Like you're just watching. I need to know that I can do this before I can let a PGY5 or PGY4 do this case. And then as you let them do more, again, make sure that you're okay with what they're doing before you don't scrub in or you're not in the room or something, because you don't know what level they're at. I did just hire a PA who started 2 months ago, so I'm in the process of training her to be as capable as Hakan and Evan's PAs are. So she came from the ER, so she's a lot of medical experience, but not much orthopedic experience. So kind of learning orthopedics, kind of like training a resident. She's essentially like a PGY0, learning orthopedics, learning surgical skills, suturing. So we have a lot of skills labs that she's attending to kind of help her get along. So it is like I'm training my resident in addition to the residents that we have. But it is really helpful to have, it's kind of like a buddy, somebody in clinic with you, somebody to share the patient phone calls with, somebody to help you offload a lot of the administrative stuff that I think people don't realize is a large part of a medical practice.
A recurring theme about training residents, Michelle. It's tough when you're on the other side, isn't it?
Really appreciate you guys now.
Well, I mean, honestly, it's one of those things that it takes time as a faculty person to kind of understand. I mean, like Michelle said, you have to be confident with the case before you could possibly teach it. I think that all of us in the faculty could probably tell you that the most important thing for us was learning how to do it ourselves. That way, when mistakes are made, we can kind of guide you through them. I remember as a PGY3 on Dacus' service, I was, he was so confident in all the things that he was doing that he was able to let me kind of fly. And sometimes it's hard to know kind of where someone stands when they come into your room for the first time. And that's why I think the preceptorship model and mentorship model that Aaron has can be helpful. You finally get someone you can take them through for 6 to 10 weeks, but then every 10 weeks they turn over. It's like Groundhog Day. But anyhow, well, thank you guys. This has all been very helpful so far. We're gonna kind of keep going through some of the things. Nicole, you're in your first year. Tell me about how well prepared you felt for the financial side of it, the coding, the billing, the contract stuff. I mean, clearly, it's a lot to take in at once.
I am still figuring all of that out, quite honestly. I think I attended a business course at AUKUS. I tried knowing that I was going into private practice and that it was going to be very important to be efficient, to be financially responsible and make all those decisions. I tried to do a lot of research, listen to podcasts and webinars, and I still am quite overwhelmed by it. Honestly, I'm still learning. I think my partners are, several of them have MBAs. They're very involved. And so I have certainly leaned on several of my more senior partners to learn the ins and outs. I do rely heavily on my coder, especially for some of the more complex revisions and fracture cases that I do, because I think there are some nuances. And I mean, all of the coding stuff, I feel like is constantly changing. And certainly from a reimbursement standpoint. So I think as a resident, trying to pay attention and talk with the attendings, I feel like that was something I just never paid attention to during residency. The attending would put in all of the billing and coding at a level 3 or level 4 visit, and it didn't make sense to me as a resident, and now I'm understanding that it's actually a huge part of practice. Being able to make sure that you're dictating the exact correct thing so that if you get audited in the future, it's not an issue. There are so many nuances to the dictation and to coding that I did not appreciate as a resident.
How about you, Hakan? Financial stuff that was a surprise to you?
Yeah, we have a billing company that's fortunately been good for us fighting for a lot of billing stuff, because I didn't realize how big of a fight it is against insurance companies. My disdain for insurance companies has skyrocketed since I've been in practice. There's lots of games they play, and fortunately we have a good billing company and a lawyer that is arbitrating a lot and fighting a lot, but it's crazy how much work is involved to getting paid to do the work we do. And so I think that was very underappreciated going into practice. I just assumed I'd be working and doing stuff and then getting paid for it, and that's not the case. You got to really especially United's a big provider around here, and they do everything they can to try to do take backs and not pay you, and you got to constantly be fighting them. So unfortunately I spend a lot of money on a lawyer to arbitrate, but they do end up getting us a lot of money back. So it's just to echo what Nicole said, is that understanding how billing works, I think you're going to learn way more once you go to the practice. But knowing what codes do pay out, I used to put code 22s on a lot of things that I felt were complex, and realized that insurance companies don't care at all, so you don't even bother anymore. So things like that you'll learn, but you have to stay on top of it, especially when your livelihood is dependent on your collections. If you're just salaried at a hospital system, maybe you don't care as much. But for me, every dollar I bring in is helping pay for overhead and go into my salary. So I have to really watch out for things that don't get paid properly or don't get paid at all. I'll notice a year out, I'll see a patient back and look back and say, oh, what did I get paid for that surgery? And realize nothing. So you got to go back and submit a new claim and all that. It's crazy what can be like.
Jeff, you mentioned you are a partner in a surgery center. Like, how did you learn about how to do that type of stuff?
Yeah, so that's completely on the job training. I would echo what a lot of the other people have said. I mean, you can certainly jumpstart your learning by paying attention to what's done during residency, what your attendings are doing and things like that. But it really is one of those things that you can't fully appreciate or understand until you kind of get in the middle of it. And you know, I'm on the board for our surgery center. And so, you know, I'm involved in business making decisions in terms of our surgery center, which is you know, a separate entity from you know, from our practice, you know, and so, you know, there's balancing, you know, those decision making, the business aspect of things from, you know, the being the physician type of decisions that you're making on a daily basis. And, you know, I would echo a lot of what Nicole said. You know, when you're out and you're brand new, it's crazy, but it's true. The surgery part of things is the easy part. You know, that's what you spent your last 5 years training to learn how to do. It's all of the other things, you know, how you want to set up your practice, how you're going to get the logistics, how you like it in the operating room, and you know, learning billing and coding and how to maximize those things, and understanding how your surgery center works and how your practice works and how you want it set up. You know, those are the things that you didn't really get a ton of training on. You were learning how to do surgery. And so it's crazy to think about it, but surgery is the easy part of the job. That's what you focused on. It's all of the other things that, you know, are a challenge, especially when you first get out.
Show of hands, all you guys have like financial advisors who are helping you out? Like, do you guys have someone who kind of helps you with your, you know, with your finances? Anybody?
Evan is my financial advisor.
What's that? You do?
Evan is, yeah.
Evan, are you guys still mining Bitcoin? I think when you guys are in Roanoke, you spend your entire time in Roanoke mining Bitcoin. You guys should all be rich by now.
Yeah.
Dan, when did you start talking to a financial advisor? Was it during residency or after you got out?
Yeah, it was actually during residency too. It's probably one of those things you can't really do too early. They usually do it for free while you're in training too, most of them, because they want you to stay with them for a long time. And I'm sure you guys get all those emails like constantly. Everyone's an expert in physician. Of course, every financial advisor wants to be a physician expert because they're going to make a lot of money. But I mean, having someone that's a little bit more financially savvy than at least I was is really helpful, just to kind of keep an eye on things, make sure I'm going down the right path and stuff. Even as simple as like student loan repayment stuff, just making sure are you going for PSLF? Are you, what's your plan there? How are you going to repay it? I think that's super helpful. Not going to take too much time. Very easy to do. Likely inexpensive, if not free for you right now. So just go ahead and do it now.
Yeah. On the PSLF thing, I actually just got my loans forgiven 10 years out. So I thought it was just like this magic thing, and it happened. So that happened like last week. So yeah,
Congrats.
Talking to a financial person can be pretty helpful. I can tell you that. That was a good surprise. So let's get some advice right to our residents now. Let's see. Ahmad, you're always full of good guidance. What advice would you give to the rising PGY2s as far as how to get the most out of their residency training right now?
A dangerous intro that is. You're always good for good advice. PGY2. That's tough. Do you
remember your PGY2 year, Ahmad?
It's blacked out for one full year. I think all of residency just seems like this constant chasing your tail scenario. A lot of trying to stay afloat and all that sort of thing. But I think that for me, the biggest thing out of all of it was, there's so many additional things outside of what is really the specific job that can get in your way. If you can find a good way, a good routine, a good mindset to cope with all of the other things, and by other things, I mean like the pressures and stress from whether it's family, whether it's outside of work, whether it's like stress about, oh, I'm not doing enough of this, not doing enough of that, and just like lean into learn all your orthopedics, spend as much time in the OR as you can. That's really, fundamentally, that's kind of dumb and mindless to say, but a lot of that stuff gets in your way of being a good learner. It's just clouding your head with some of that. So I love orthopedic surgery. I love doing surgery. A lot of that other stuff, including some of the things we've just talked about, like outside of hospital stuff, that gets in the way of the part of the job we actually love and do. So finding ways to say, you know what, there's such and such BS I have to deal with, I'm going to deal with it, but it's so that I can do the orthopedic surgery that I love. Once you can manage that, the rest of it's okay.
How about you, Trent? Do you have any advice for rising PGY2s?
Yeah, I think, depending on what practice setup you're doing, all those rotations can come back. So, making sure, if you're not going into arthroplasty, that, you have good notes on techniques and, post-op follow-ups and kind of everything for that. Cause it can be a couple years, if you go on to, I hadn't seen a hip in, a year and a half, and then you get out on a call and you're the person on call, and that can come pretty quickly. So, it can be years in the future. So keeping good notes, I think, one thing we did in my fellowship, because we had a lot of fellows, we all made kind of a shared Google Drive that everyone still uses with just notes after notes on it. People would copy and, operative reports, which is helpful for not only technique, but dictation too, that you see. So, watching what the attendings dictate in terms of, documentation can be kind of nuanced too. So I think that's helpful to start early. And then by the end, you'll have this big drive that we all shared with in different cases, different techniques, different specialties too, op notes, post-operative protocols and stuff. So, with everything, you can make that shared, that you can continue to use. We still all use it this day too, especially like the op notes and stuff. Like everyone's been said, if you don't use a certain phraseology, you might not get paid. And some of the insurance companies are looking for very specific things on some of the procedures to get paid. I think that's helpful. I think the other thing that, can, like everyone said, in the operating room tends to be the smoother part early on. I mean, you'll have your stuff happens and everything too, but clinic is huge. I think that's where a lot of times you can get into trouble. That's where kind of the beginnings of bad decisions can be potentially made. You're dealing with personalities, workers' comp. I see a lot in Pittsburgh early on. That's a completely different beast. So seeing how different attendings act to different personalities, how you handle a complicated patient or an unhappy or frustrated patient in clinic, it happens to everyone too. I mean, in the operating room, everything's kind of smooth, but a lot of that stuff, the discussion, the decision-making is based upon clinic and your rapport with the patient. So seeing how attendings establish rapport with patients, that's huge. Gaining patients' trust, even if something doesn't go particularly smoothly or, optimized, if that patient trusts you and likes you, that protects you a lot. So I think, never underestimate that kind of stuff too, and using clinic and how you approach patients.
Can I jump in, actually, Dr. Gwathmey? Because I didn't start this until fellowship. I didn't start this until fellowship, so I just want to say if I can go back, I would have started this in residency as well. As everyone said before, that most of the time you're doing cases with your attendings, everything's going smoothly and everything goes exactly as planned, and so you memorize and learn how to do things with everything going smoothly. I think really, not that you wish this upon your attending or the patient, but really pay attention and really start focusing when things aren't going well and what your attending is doing. In fellowship, when that would happen, I would really kind of try to memorize every single detail of how they're problem solving, how they're figuring it out. And I'd go write all that down. So I had this big book of like when shit hits the fan, excuse my language. And I think that is huge because, like everyone has said, there's going to be times where you're like, whoa, this is nothing like what it was like in residency. Everything was smooth and perfect. And then you're all of a sudden the attending and it's not. So really try to memorize those experiences and kind of how your attendings, people that are way smarter than you, work through it. I think that was huge.
Yeah, my goal as a faculty member was to give you guidance on when shit hits the fan. Like, that was my clinic. That's why I was so annoyed by Dr. Dix in the back of the, like when I was in Dix, like everything went so smooth. And when I got into practice, I felt like everything was just like in disarray for my practice.
It is. It's crazy. Yeah.
It's crazy how but I'll say that you end up focusing, and this is maybe a comment I can make to you all, is that you focus on the negatives. I mean, you might have 9 or 10 patients doing fabulously, and then one person who's not doing as well. And the entire day is ruined by that one person who's doing poorly. And it's just crazy how your brain sets up that way. But I would encourage everybody in the room to realize that all of us kind of go through that same exact process. And even Dr. Diedick in the back, if you got a bad outcome, which he never has, but if he did, it does start to, like, it wears on you, but you have to kind of compartmentalize that and keep it kind of separate from the other stuff. Otherwise you'll get tortured by it. Evan, we have some PGY4s about to enter their chief year in the fourth row on their computers right now. What advice would you give to them as they get ready for their chief year? How do they get the last, like, the drop out of residency?
Yeah, I mean, I think pay attention, right? I mean, I think it seems like, kind of off the cuff advice, but I think the hardest thing for me was some of the little details, right? It's like, I do arthroplasty, I'll do total knee, total hip, and total shoulder. And I didn't do much total knee and total hip while I was in fellowship. I tried to seek that out and go and see it as much as I could. But I think little stuff like retractor placement is something you don't think about. And again, that's not just for the PGY4s. I think that goes for every single level. If you're retracting, I know it seems like, man, you're like, the knife, you're not actually operating, but you need to pay attention to the little things that are going on that's outside of the dissection. Because again, you're going to understand and you're going to know the planes in which to do these procedures through, but you also need to understand where, how are we seeing this so well? How is it because we have 15 sets of hands in here, or is it because the attending who's kind of running the show there actually knows that, good retractor placement makes a big, big difference. So I think there is a little bit of a little bit of benefit in the minute details that you can learn at every level. I think it's the PGY4 going into your chief year level. I think you're anticipated to now be one of the leaders. So I think you want to, kind of lead by example and then learn as much as you can, good and bad. I mean, you're going to see, you're going to get, well, I really should say, you're going to get advice pretty much every day and, get in, try and improve every single day. But I think you have to try and figure out how you can implement that. And at this point, you may have a better idea of where you're going to be going. I guess I don't remember all the timeline. I apologize from a fellowship standpoint, but I think the match and everything has occurred. So I think that once you know what you're going into, whether that's straight into practice or if that's into fellowship, which is likely for a majority of y'all, you need to make sure that if you're planning on going into a private practice gig where you're going to take general call, make sure you can still do the general stuff, because you're going to do 1 year of very subspecialized training, and then all of a sudden you're going to be jumping back into where your periprosthetic fracture shows up, and you can't just dump it to Aaron Casp down the road. So you need to kind of figure out, how are you going to manage that stuff that's not so much something you focused on in the previous year when you go into fellowship.
I want to say thank you. Dr. James Beamer Carr is entered the chat. So Dr. Carr, will you tell us when you graduated, where you did fellowship, where you are now? I was doing some surgeries and something.
Exactly. Graduated UVA 2018. Did sports medicine shoulder fellowship at HSS 2019, and then currently at HSS Florida in West Palm Beach. Been here for now. This is year 5.
So I'll give you a question right now. I just asked Evan this question. For the rising chiefs, do you have any advice on how to get the most out of their chief year?
I think just get us, just don't mail it in at any point. Keep learning. I think I echo what everyone said about learning more in clinic. Hopefully you've got a pretty good base of operating skills being a UVA resident. Keep growing that. But I think clinics where there's a lot of angst your first year, because you really have to, a lot of times you show up to the OR, the patient's already been worked up, indicated, they have all the imaging studies they need. And, it's really clinic is what gives you a lot of angst in terms of, dealing with complications. Do I take this patient back and wash them out now? Do I wait? Do I give them antibiotics? Do I, sit on it? Am I aggressive? Am I over aggressive? Am I not indicating enough patients for surgery or vice versa? So I think that's important. I think too, for me, I wish I would have had a better sense of when good enough is good enough in the operating room. So my first year was extremely stressful because I just felt like you had to get everything perfect. And I would, it's really kind of trying to learn when is good enough, not to, and when do you need to do better? So, every patient needs to have the best outcome possible and get the best surgery from you. But sometimes you can do more harm by trying to make it perfect when it's already good enough. So I never had a sense of what that was going into my practice. And as a result, it caused a lot of angst. So definitely just getting a sense as you're watching your attendings operate, you can ask them why did you switch out that screw and put a different one in, or why didn't you, I think asking those hard questions in a humble way is a good thing, and really gets you, prepared to make those decisions. And the last thing I would say is what I tried to do is I tried to ask myself, what would I do if I was the attending right now? And I was the only one in the room. So you're in a case, you blow out the back wall in an ACL, or, it happens. Not that that really ever happens much with UVA surgeons, but you see something, okay, what would I do? All right, I have a little crack in the femur now. Okay, what am I going to do? How am I going to approach it? Am I going to leave it? Am I going to wire it? Am I going to plate it? I think just learning and putting that pressure on yourself as a resident when you're not making the decision will prepare you to start thinking through, what would I need if that happens? Okay, well, do I have that available for me? So I think, thinking ahead and pretending like you're in that attending position is invaluable.
All right, so Jeff, you take general call, correct?
I do.
Okay, what do you think, like looking back at your residency, what cases outside of what your fellowship specialty do you feel like you were least prepared for in general call, or which cases do you think you should have done more as a resident?
Well, for me personally, and I'm sure this is not necessarily the case, but due to some circumstances when I was there, I had fairly limited, foot and ankle experience where they were shifting when in the residency we were doing that. And so I was one of the lucky residents who got basically twice as much spine and half as much foot and ankle, which was awesome. But no, I mean, I feel very prepared for those things because you get enough of that on trauma. But I do think that there are some principles of foot and ankle surgery that personally I was a little less prepared for. Like I understood the principles, I understood, what's an emergency, how to deal with those things. But I think if there was something lacking for me, like for instance, I don't know, in training, probably a dozen or so, Achilles chronic reconstructions, VY turn downs with FHL transfers. And I never fixed an acute Achilles, tear. And that's part of just being in a tertiary center, a referral center like UVA is. But some of those principles and exact circumstances I was a little less prepared for, but I really don't feel like I had any major deficiencies coming out. I felt extremely well prepared. When you leave residency and you go into practice, you naturally have a fair amount of doubt and oh, am I ready? And then you get in there and you start doing it, and you actually realize how well prepared you are coming out of a place like the University of Virginia. And a lot of times you even early on, you end up surprising yourself. You wonder if you can handle a complex case on call, and you do. And, you realize that, you really are well prepared. So, I didn't feel like I had any major deficiencies. I do a fair amount of, level 1 type trauma, even though we don't technically call it a level 1 trauma center. The university hospital is frequently on diversion here. And, that was actually one of my fears coming out as a private practice hand and upper extremity surgeon. Am I just going to be doing carpal tunnels and trigger fingers all day? And that was one of my real fears, because I did not want that to be the case. And nothing could be further from the truth. I do a lot of complex hand and wrist, but I also do a lot of, complex general trauma, and I enjoy that, and I find that stimulating. And in general, felt very well prepared coming out of UVA for that stuff.
How about you, Michelle, academic sports surgeon? Are there any cases that come through the call that you don't feel quite prepared for, or what would you say?
I'd echo what Boatright said. We are very well prepared. I will say my chief fear that we had pretty handsy joints fellows, so I hadn't done a hemi for a while when I first started. So kind of watching some videos. Remember, I watched one with Tom Brown before doing a lateral approach, so I know it was okay for a surgeon to watch YouTube before doing a surgery. So reminding myself how to do the approach and like where the retractors go. But otherwise, everything still scares me. So Max gets a lot of texts from me when I'm on call of what to do. And then he reminds me that I know what I'm doing and reassures me that, yes, I do know how to fix this fracture. But like relying on people like Max and other people who have experience in trauma when you're on call, just to run your plan by them and say, am I doing this right? Do I know how to do this? And then they say yes, you say, okay, I can do this. Just because I mean I'm early, so everything still is intimidating. But once you're in the OR, you just remember things. Like if things go wrong, you say, oh wait, no, Yarbrough did that once and we fixed this. Or I remember this happened with Weiss and he used this plate instead. And so things come back to you. And you have the foundation. So you adapt to a case, you adapt to something you've never done before. A lot of cases you do in practice you've never done before. And so you have to just rely on your basic principles that you learn in residency. And we're lucky to really have a wide breadth of knowledge that you can draw on regardless of what case it is when you're on call, because you don't know what you're going to wake up to on Saturday morning, and you have to be ready both with your own skills, and then a quick text to Max is always very helpful.
Ahmad, what do you think we're doing too much of here at our residency program? Talk to the program director. What do you think I could do to help out, make the training more efficient?
You got to dial that in a little bit more. That's a big old question.
Good question. It's a question from the group. I think Neil Blanchard wrote this question. The question exactly is, please list any call cases you felt over prepared for ordering practice, i.e. you needed fewer cases during residency.
Oh, that's not a thing.
That's just fine.
Yeah, that's not a thing. There's no if you have a variety of call case experience under your belt and have seen it a million times still, when you do it on your own, it's going to be totally different. So there's whatever call cases come to you, great. I mean, the majority of folks in the room and on this call are not going to do level 1 trauma, and that's totally cool. So I think that the question of what didn't you get as much experience with is way more pertinent. But I mean, you're going to be nailing old lady hips, you're going to be doing hemis, you're going to be doing long bone nailing, tibia nailing, all that's fine. So as long as you feel good with that, that's great. I'll echo Michelle's statement about not a lot of hemis. That's the thing that's like truly a part of being outside of UVA. Like when you're on call, you're doing it. It's not going to the recon team or anything like that. So things like that, just be ready for immediately when you get out. But there's no such thing as too many overexposure to call cases.
I'd say that I'm sure everybody on this alumni chat realizes we've pulled all of our residents from Roanoke this past year. So starting January 1st of 2024, we no longer go to Roanoke at all. And one of the concerns is the lack of exposure to things like hemiarthroplasty and things like that. Can you kind of Dan, maybe you can comment on, you probably don't take a lot of arthroplasty call, but I don't know, what are your thoughts as far as like, how can we get more exposure to that here as a residency group?
Yeah, I don't do any of that at all. So I'm the worst person to ask, but just in general, I mean, I think that, I was sad to hear that pulled out of Roanoke, because it's just a different experience. I mean, you have the high level academic experience in Charlottesville. I think that you're going to get a way of doing things that's not like a lot of places if you're not practicing at an academic center. So I'm sure you guys will figure out a way to broaden the scope of exposure, but ask somebody else.
I'll piggyback a little bit on that. Just the only thing I can think of with that standpoint is that from the Roanoke side, we would see a lot of different implant companies. So I think sometimes you just need to, be certain that you may not be going to a hospital that's contracted with Synthes and Arthrex and Smith and Nephew. So there is other stuff out there. There are a lot of mimics. There's a lot of stuff that's made very similarly, but I think you can get exposure to that at stuff like Academy, at any sort of meetings. I mean, I know visiting the vendor booths is not always the most exciting thing to do, but that is one place that you can see some of the products that are out there. And I think that's, Roanoke was a good wealth of knowledge when it came to using varied stuff. And again, that may have changed over the last, 5 years or so at UVA. But again, you will find that there are other vendor companies that some of these places contract with for various reasons. So it's important to kind of know what they have in their armamentarium. And if you do need something different for a particular reason, having a good reason to use that is helpful.
And can all of you can comment that, the practices you walked into all had vendor contracts with certain companies, right? All the hospital systems you walked into. So it's not like it's a free for all. You can use anything you want.
Yeah, no, I mean, I think that's very true. You know, a lot of the places, at least down here, they're a little bit more amenable to me justifying why I was using a particular thing. You know, our surgery center hates that I use anything Arthrex because they're all their reimbursement and rebates come from Smith and Nephew products. But again, when you've trained on something for a long period of time, I think you know keep in the forefront of your mind that doing the right thing for the patient is way more important than the bottom line for the surgery center.
All right, so sorry, I had a question for Nicole, but she's just she's trying to get your connection just lost. So let's talk about some other things. So for the graduates who are about to go into fellowship, can I get some tips about getting ready for fellowship? How about you, Hakan? Like, what's the best way?
So going into fellowship, you know, I knew that was like kind of the final hoorah before I was off to practice. So really just focused on making the year, doing as much as possible. I think my case count for fellowship year was over 500. I was just trying to get into every single OR, every single clinic, and just my wife was on board. I told her I'm just going to disappear and just do as much as I can. And I think that was a great experience. I was fortunate enough that my fellowship allowed you to actually be an attending. And so I think I got that kind of first year jitters mostly out during fellowship. I remember my first type 3 supracondylar pinning on my own, where my backup attending was an hour away. I was sweating bullets for no reason. I mean, I've done 200 by that point, but it was the first time I was on my own, knowing that there was no help. And I think kind of getting that out of the way, it became a lot easier. And so I think just going with the mindset to do as much as you can, and really learn from your mentors. Because for the first couple of years, I was really texting a lot of my attendings from San Diego. You know, what can I do with this? Have you seen this before? Because you're not going to get it all, no matter how much you do work. And so establishing good relationships and you know, knowing that you have them as a resource is huge. So definitely be friendly to everyone and establish good relationships and learn as much as you can.
So Nicole, how's your connection? Are you good? Maybe a little bit. Sorry, Nicole's kind of having a little bit of connection.
I'm good.
I'll wait on for a little bit for you. How about you, Michelle? How did you get ready for fellowship?
I think taking a lot of notes, just making sure that you know what technique you want to use, which technique you like. You can blend techniques, both from taking notes as a chief in residency, from how UVA attendings do things, and then translating them to your fellowship. Because everyone does pull shoulder differently, the approach is different. Everyone does their cuff suture management differently. Kind of getting a feel of what you think would be helpful. But I also go into clinic. We didn't do much clinic as a fellow. We had a lot of sports coverage responsibilities. And so that obviously goes by the wayside. You'd rather be in the OR and cover sports and then not really go to clinic. But clinic, I think Beamer mentioned, is fairly intimidating as an attending. People are sitting there looking at you for an answer, and you need to give them an answer and correlate your physical exam with their history and what you want to do. And do they need surgery? Did they do enough PT? Did they do another injection? Kind of when do you want to indicate someone for surgery? And so I think watching how people interact with patients, both patients who are doing well, patients who are doing poorly, is really helpful as a trainee. Even if you're a fellow, you're still learning from people and learning how they address things and how they run their clinic. So who's helping them? How are they doing notes? What are they doing notes? How's the flow? Who's doing injections? Are they doing the ultrasound? Are they referring them out? Just things to make their flow to match. When you're starting, you're going to come up and they're going to say, well, what injection concoction do you want to use? Like how much lidocaine, how much Kenalog, what needle do you want to use? So kind of taking notes of how to streamline things when you start, because people are going to ask you and look to you for questions when you're an attending. You're going to have to provide them with answers. So taking notes during fellowship, and when you're a chief and as a resident, just at that point, you have your base as a chief, just like Evan said, just pay attention to the OR, pay attention. Sometimes not scrubbing in can be helpful, even though you want to be involved in the case. One day, Brock Marvel moved the arm, you can see super well, and then you're doing the same case and you move the spider and you can't see anything. Like, what did he do with the arm? He's not going to verbalize it. It's something that you're going to watch when you're not scrubbed in or when you're not super involved in the case. So I was told to watch cases as a fellow to get the nuances that for exposure, or kind of in an arthroscopy, kind of moving the spider kind of really to expose things, I think is helpful when you want to be involved, you want to be in the case, but you know the approach, you know how to read, you know how to pass use this work, and you're not going to do those skills as a fellow. It's going to be more high level things that are going to be applicable when you're the one moving the spider, you're the one kind of managing how your clinic runs. Those are things that we don't tend to focus on because they're not as, you don't think they're important, but as a chief, as a fellow, you have your base surgical skills, and it's the little nuances that you need to focus on.
So Nicole,
Yeah.
hopefully you can hear me. Oh, go ahead. You have a question, Jeff? Is that you?
Well, no, I was just going to kind of piggyback on some of that. Fellowship is such a cool year. It really is. It's a year where you get to really just hone your skills and take a deep dive. Residency, you're learning the principles, you're learning the approaches, you're gaining surgical skills. And by the time you reach fellowship, you have a pretty good grasp on that stuff. But fellowship is a year where you can really, pay attention to how your attendings think, how they approach challenging problems, how they look at a challenging case in the clinic and think about it and come up with a surgical decision, and then how they go about executing that plan in the operating room. And then if things aren't, going as planned in the operating room, how they think about that problem and how they adjust. And it's really a year to, fine tune your decision making and how you approach problems and melding the different approaches from your different attendings and developing a style of your own and how you're going to plan to do those things in the very near future when you get out there on your own. And, I think back on my first couple of years of practice, and it was virtually on a daily basis when I would think, I can see how, Chabra approaches situation or how Dacus approaches situation and how I then utilize that in a direct translation into, how I'm now approaching that problem. And so it's really a year where you get to, fine tune those higher level decision making. And, it's those things, it's the decision making and the approach to challenges that are often the difference between a smooth case and a case that, doesn't go as smoothly as you would want it to. It's not the execution or the surgical skills. It's the intraoperative decision making and how you approach problems. That's often, the difference in whether or not something goes smoothly or, whether or not, it's a challenge. And fellowship is really a year where you get to, meld all those things together and fine tune those things. And it really, really is a cool year.
Thanks, Jeff. I kind of like this line of questioning up.
I say one more thing, sorry. With what Jeff was saying about clinic and watching how attendings talk to patients, you're going to go to fellowship in a different likely city or practice setting than you did residency in. Patients in New York City are very different than patients in Charlottesville. My patients want an MRI yesterday and they want surgery 2 weeks ago. Patients in Charlottesville say thank you. And so really understanding how the patient's expectations and how people manage them in different settings and how you help reconcile that no insurance has to approve an MRI before we can get it yesterday, kind of really explain things to patients and how your fellowship attendings manage expectations in a different practice setting. Patients are not the same in every city. And I think fellowship exposes you to a different population to learn how to treat different patient personalities.
How about you, Dan? What are your thoughts about fellowship, getting ready for fellowship?
Yeah, I echo everything else everyone else said. One, like logistically, okay, so everyone talked about like, you got to take good notes. One thing that I thought was really helpful for me in fellowship was, so I had co-fellows, I was one of 3 people, and we all did an Evernote, which is that like online note-taking site. We had a shared file with all of us, and basically we did like rotations through sort of like an apprenticeship model for like 3 months at a time. And basically we would, for every single case, write as much as we could about that case with that attending, notes, etc. Because especially in hand surgery, there's so many different cases, you're not going to see every single one. But between the 3 of you, you see a lot of them. And so having that shared file, one, it makes you look slick when you're on that attending service that you haven't yet rotated on because you have all of the previous fellows' notes about how they like it set up, how they like it done. But two, it sort of broadens your exposure to things. And then it becomes three, really a complete invaluable resource afterwards that I still sort of look back at and stuff like that. So I think that that's a really big thing. Just having a way to actually like take the notes. I remember residency, I did a lot of drawing and stuff like that. And I still have these books that I wrote down on my surgical notes, which is great, I think, as you're learning, but I think having something that's a little bit more, mineable and able to look back at in a quick way is a good way. And I found Evernote to be pretty helpful for that. The other things I would say about fellowship is maybe controversial, but kind of what Michelle said, like, don't be afraid every now and again, like, to give the knife back to the attending. Like, I thought that like some of them, like, I wish I could go back to fellowship right now, or just like a month and just like watch, like even go back to UVA and watch Dacus do a couple things, travel, just like to have them do it and you just watch. I just want to watch you guys do surgery, just to figure out, because now you know how to do it. You want to learn from the tips and tricks of X-ray. I don't need to watch myself do it anymore. So I think like really every now and again, maybe ask your attending, like, why don't you do this? I don't know. If you're in a good situation, you do this case. I just want to see exactly how you're doing every single step of the way, positioning from, closure. And then I think if you have an opportunity to work with like sort of the other end of the coin, like junior faculty in fellowship was actually pretty cool too, just because they are closer to your level and stage, and you can, you're figuring out problems like together. So working with the other like co-fellows, I think was awesome. If you guys can do cases together, it's I don't know. I think it's better than just doing it on your own, because if you're on your own, you're gonna you fall into your own habits, whether they're good or bad. But if you have someone else kind of checking on you and bringing another perspective, even that it's not that person who has 40 years of experience, this person has like 4 or 5 years of experience. I think that's awesome. I mean, I think that goes for fellowship too, or for residency too. Actually, Ahmad is no longer on, but actually, he's on. I actually really appreciated when Ahmad was a young, hungry junior faculty member at UVA, a year ahead of me. I really like just like working with Ahmad in the trauma room, like, because again, I mean, he was certainly a better surgeon than I at the time. Maybe I've caught up, but it was really just like the two of us just like totally figuring this out. Like Weiss knew all the answers, and he knew exactly what he's going to do, plan A through Z. But Ahmad and I were really just like trying to figure things out kind of together, which I think that was really cool. So, especially in residency, don't shy away from the junior faculty, give them a lot of look too. But in fellowship, yeah, I think, all those things that I mentioned.
Beamer, we have got some fellows in the room. They've got 3 more months left in their fellowship. Do you have anything they should do their last 3 months to make sure they're ready to start?
I think everyone's giving great advice. I would say be thinking too about what you want your overall life and practice to look like. You need to be setting yourself up for what's going to make you happy in your practice, and that looks different for everyone. Some people just want to be really clinically busy and they don't really, put as much talk in the academic side. Some, academic advancement is real important. They're being involved in the associated societies of your subspecialty and advancing within that. If you're doing sports, what kind of sports coverage do you really want to, have? Some sports people love, certain types of sports coverage, high school, college, pro. I think it's important to kind of, make sure that you are setting yourself up for that side of it as well. And for those who are a little further behind, really start thinking about that. When you get to fellowship, if you don't have a job, talk to your mentors day one, of what you're looking for and what you want. And if you don't know, talk with them through it. But in terms of the last 3 months, I mean, if you waited for the last 3 months to, get where you need to be, you're probably behind. So I'd say, go all out, but hopefully you can just, refine, like do an honest self-assessment, see where you're at and what your, kind of what would give you the most angst, if it walked in your door, 5 or 6 months from now, and just attack that for the next 3 months and just enjoy it. Like, you're going to figure out the first year stuff. It's going to be hard. It's going to be stressful. It's going to be fun. It's going to be all the highs and lows. So like, enjoy your last 3 months of like operating on someone else's dime and building those relationships and getting that mentorship, because I think all of us would love to spend a month with our residency / fellowship mentors and just, get that extra level of mentorship. So enjoy that side of it.
We have a question from the back. Dr.
Can I add on real quick?
Yeah, sorry, Evan.
No. I was just going to say for the fellas, and I'll let Dr. Dida go, but I was just going to say for the fellas, last 3 months, go and see, if you're going into a general practice like I am, go and see the stuff that is common general calls that we've kind of talked about today. I think spending some time seeing total hip retractor placement, going and seeing a Hemi done is invaluable, because you will get in there and, like we've all echoed this entire time, you have no idea who's going to be helping you the first year. And you may get into a situation where you're like Nicole and you have somebody across the table who's trying to reduce this hip, and next thing you know, they've cracked the femur. And you need to know how to manage that, because there's no one that you can call somebody, but there's no one coming in to usually bail you out. So go and see some other cases outside of sports. If you've got any sort of free time, jump into the trauma room, show up on the weekend, and do something like that. We spent a lot of time at Rady when I was at Emory, and we would still go back and when we had some free time, or when the Falcons or someone were out of town, and you could go and see some of these other cases, and I would go and do total hip and total knee, knowing that I'd be doing some of that in practice.
Morning, guys. I just a question for Nicole and Michelle. Any unique challenges as being a woman going through training and starting practice, life, orthopedics, the training process that you can share, and how you managed it?
Nicole, maybe you can start, since so Nicole had her son when she was a PGY4 resident. So maybe you can talk about work-life balance and just kind of what it was like to do that.
I mean, being pregnant in residency was tough. But it's a challenge every day. I think having a supportive spouse has been paramount. I think regardless of your gender, having family that is there to support you. One of the reasons that I wanted to end up in the Carolinas, and I was very specific about where I wanted to be, was so that I would have family nearby, because I think it would be infinitely more difficult to do what we do and not have any family nearby. I think that being female certainly presents different challenges. I think there's just some inherent differences in being a mom. I think there are certainly in the first year, there's certainly a lot of things that come with having a child that are unique to being female. And I don't think you can get around that, but relying a lot on your co-residents and I think was important. I think in practice, my practice is 29 orthopedic surgeons. I'm the only female. It's been a unique challenge to join this practice, but they are very supportive of me. I think I see a lot of patients that are very happy to have a female orthopedic surgeon. There aren't any others in the area. And so I see a lot of patients who come to see me specifically because they want to see a female surgeon. I also still get asked if I'm the PA, if I'm the assistant in the surgery, despite the big MD on my jacket. So it is, I think it's still something that is every day it brings new challenges, but I think there's a lot of benefits also.
Michelle, anything to add?
Michelle, I don't know if you have.
No, yeah, I mean, I'd echo what Nicole said. I mean, well, there's inherent challenges to being a female in a male-dominated specialty, but having our core group, I mean, we have our female group chat from UVA that is fairly active. And I guess Nicole said we talk very frequently about patients. So having support of both genders is helpful, but having people who are going through it with you. I mean, like Nicole, I'm the only female in my section of HSS. HSS Sports has some female surgeons, so we tend to band together. There's some young female surgeons who we talk about our inherent challenges. And so having both the young female and then one of the elder female sports surgeons is kind of taking us under her wing. And so we go to dinner and we talk about things that male surgeons don't have to deal with, or things that they don't really see. I think starting out as a female surgeon can be difficult. Sometimes you don't get treated the same kind of respect from OR staff, or clinic nurses can be different when you're a female. Just some slight kind of tone or biases that people have that you have to, I mean, I sometimes still act like a PGY2. I set the room up, I clean, just because you feel like you want to show that you belong and that you're a contributing member of society. And so you try and show the staff that you care, that you're a good surgeon, that you're trying to help everybody, and try and build your rep that way, which I think as a female, you might feel that you have to, just with the way that some of the staff behave towards you, which I think you eventually realize that you'll grow out of that and you're the surgeon, you'll gain respect, but sometimes that can be difficult as a new female surgeon in a new practice in a new location where nobody really knows you. You don't have a background and people don't know who you are. But I think having the support of people both in your practice and outside of your practice that you can rely on and call about any problems or just vent about your day, and kind of patients that kind of rub you the wrong way, or patients that, like Nicole said, came to see you because you're a female surgeon. I've had some of those who they prefer a female surgeon, and then I had a hip fracture who in the OR before going to sleep said, you know what, I want a male surgeon. So it was 4 p.m. on a Sunday and I didn't fight her too hard. So we sent her upstairs and my male partner did her the next day. But some people just kind of have their thoughts and their biases and you have to accept them. But I think our specialty is definitely growing and accepting of all different genders and races and all different diversities. And I think that's great for our specialty and for really everybody. And I think being a female surgeon will be less difficult as we go ahead. But I think Nicole and I have had a pretty good time of it, and really having each other is really, I think, the most important part.
So 3 out of 5 of our incoming interns will be female. So it's a wave that's coming to UVA Ortho. It's been really good to see. I feel like, Michelle, you're always the elder female surgeon in this group chat, but so I
usually have more wisdom than me. They usually teach me things still.
What's that? Yeah. So Ahmad, I like giving you the tough questions. What advice would you give to the program leadership at UVA to improve the training experience for our residents?
The first advice would be to check out Beamer with his helmet on.
He must be
really sorry, getting ready for the OR. About to hop off, but I appreciate y'all. I want to hear Ahmad's answer though. I'm all ears.
Yeah, I mean, I would lead off with it. You don't really appreciate what you got until you can reflect on it. I think we got great training. I look back at my training and it was very good training. I think one of the things that would be helpful is that a lot of the stuff that we have touched on, like, oh, that stressed us out when we started practice, or little things that we wish we had paid closer attention to, I think it would be helpful with senior residents for, PGY4s, PGY5s, when you're doing cases together, talk through those things. Like, I don't feel like if I had to look extra hard or find reasons to ask questions, to poke and do that, to sometimes be like, why did you put that retractor there? Or why does this look the way it looks now? And why do I suck at it? Like, vocalizing those things and showing us like, oh, here, this is the wrong way. This is a better way. For the end of training, I think would make that transition to beginning of practice much nicer. I think a lot of those things sometimes become a little bit second nature to someone who's done it for years and years and years. And that's a really hard teaching moment to either get from someone or to find from someone. That combined with, like, I think personally, the thing that I remain most deficient on is a lot of the bookkeeping of our occupation, like billing and things like that. I wish that we either could have some portion of training that teaches senior residents that, or focuses on that a little more, or gets us geared for what to look for and what not to look for. Not in a way that's okay, here's a grand rounds, we're going to have so-and-so come talk your ear off for X amount of time, but maybe something a little more integrated into it. But I mean, those little nuances at the end of training. Beginning of training is drink from the fire hose, but I think at the end, a little more of a cherry on top would be great.
You guys are, I spend 3 to 4 hours a week looking at every penny that's spent in our department and every dollar that comes in and every case that's denied and every MRI that's denied. The finance office is next to my office for a reason. You guys are welcome as chief to come spend time with me. You will want to kill yourself, but you are more than welcome to sit in my office with me during those meetings every Wednesday.
I don't think that's the fun way to do it.
Well, the thing is, like, you know, it almost takes learning on the job to kind of learn how important some of that stuff is. And no matter how much we try to do didactic stuff about those types of things, I think that's why these alumni panels are really helpful for you guys to understand kind of what the real world kind of looks like. Trent, I want to ask you that same question. You're a little closer to training. What do you think this program leadership we could do better to prepare you for the real world?
Yeah, I mean, I think, you know, I definitely agree with everything that Ahmad said too. I think, you know, the other thing that was kind of a totally new branch is, you know, some of the legal side of medicine too, you know, that can come in based upon your practice setting too, with, you know, workers' compensation and stuff too. I think that'd be, you know, helpful to have some understanding of, you know, how to navigate some of these scenarios. What, you know, within my first 6 months, a workers' compensation case was denied by the agency. And so that involved the patient getting a lawyer and having, you know, I'd got deposed too. And, you know, it's sometimes you can get contacted by lawyers and it's not like always malpractice or anything too. So, you know, having some sort of foreknowledge about that was helpful. You know, granted, it can vary from state to state, but kind of understanding, you know, the basics and, you know, what that process entails, because it can kind of blindside you, and you're dealing with a defending lawyer and, you know, the lawyer on the patient side as well too, and, you know, what they're going to ask you, what you can say, what your responsibility is, you know, how to protect yourself with some of that stuff. And a lot of it's nuanced, but, you know, even understanding the differences between, you know, a second opinion versus an IME on some of those workers' compensation. And again, this can vary too. You're gonna have to look at it in your state too, but having, you know, some general education that might be helpful as well. I think that was kind of one of the biggest things that was a new part of early practice that can come very quickly for you. You know, and I think to kind of echo what everything else has been going on, it's, you know, having potentially, I know in the past there's been kind of a chief-led clinic where you can follow up some of your own patients too. I think that's very helpful. There is no kind of simulation that you can run that really prepares you for making these decisions all of a sudden. And it does come overnight. You know, once you graduate fellowship in that first day, you know, you're going to get approached by a patient and you are the expert, you are the last line for some of these people too. So, you know, having that ability and that kind of pressure to make those decisions too, while still having some backup would be kind of a nice step up to transition, and, you know, carrying that on into fellowship too, because that can really kind of tie you up the first couple years too. So I think that'd be helpful. And then, you know, I think on the resident side of it too, also, like I think it was Nicole earlier said, it can be very isolating very on. You're kind of by yourself. You're the only one in the room. You are the quote unquote expert, but you're still certainly learning, you know, especially with the variety that I see in hand, upper extremity. There's stuff that I haven't seen, stuff that I've maybe done once, you know, 4 years ago. So coming together with not only co-fellows, but I know some of my best memories from chief year were operating with those people in my class and doing just joint call cases that are very fun. You also get to see that, you know, people have different skill sets, but you're all kind of very similar as well. And that kind of does give you kind of that mental fortitude that, because it can be isolating. You're on your own early on, and if stuff doesn't go, right or something, it's easy to get bogged down. So, on the resident side, it's always nice to come together. I mean, yeah, both in fellowship and residency, some of the best kind of experiences were when you kind of are doing, for me, a hand replant with, a couple other fellows late at night, or, even a general call case at UVA. I think it was a pediatric case, like our chief year two with it's like a lower extremity nail, which is just very fun to kind of just see everyone kind of come together, and, gives you that kind of, where the understanding where other people are as well.
That's great. Beamer, looking good over there, man. Are you just carrying your iPhone around with you, the OR? Is that what's happening?
No, just I'm about to hop in there, but I got it on my phone.
What case do you have coming up?
Kind of a standard or simple day. I got a reverse, a knee scope, a quick elbow case, and a quad tendon repair.
That's awesome. It's
a little
funny.
bit of a grab bag.
I was telling I forget who I was talking to, but when applicants ask me like kind of what I'm most proud of as far as this residency program, this the graduates for sure, and seeing all you all doing so well in your practices just really, to me, is where I get my gratification. I'm sure Bobby and Keith would agree. So it's kind of exciting to see all you guys doing this. So we're getting, I know you guys have clinical stuff you have to do. Do you have any other questions from the crowd I haven't asked from the residency? Alyssa, do you have any questions, or anybody else? Alyssa's got a question.
Have you guys changed jobs, thought about changing jobs? What would push you to change jobs?
The question was, have any of you all changed jobs, thought about changing jobs, or what would push you toward changing jobs? Or are you in the right job? Anybody?
I'll answer real quickly. So I'm in the process of possibly changing jobs. And I think, we got to catch up, Winston. But I think the biggest thing is just, a lot of people change. You don't always know what you want. It's kind of like dating. Some people marry their high school sweetheart and just kind of find what they want right off the bat. Some people have to date a couple people to find out, what they're really looking for. And you think, and then, you date someone, then you realize, hey, maybe I don't want that in someone. So, I think the job I'm at now
Beamer, don't we?
Yeah. I think the job I'm at now is very good, but it doesn't quite have some of the things I'm looking for, kind of big picture in my career. And if a good opportunity presents itself, I think you always have to kind of be open to it. And I think you just have to really rely on your mentors from residency and fellowship. And once you kind of hone in on what you do want, you need to use those mentors and see. So it's hard. It's a really hard process, especially if your family's involved and, having to move family and you put roots down somewhere, but a lot goes into it. But I think you really just have to be honest with yourself and say, no job is perfect. The grass always, I'm a big believer, if the grass is greener on the other side of the fence, you need to water your own grass. But if you can't water your grass to make it what you want, or you need a certain type of grass that just isn't available to you, then you have to go find it. So, I think you just have to just be honest with yourself and what you want and how your, career trajectory is and go from there.
I love how freely you're speaking about this in the hallway of your operating room. So
that's right.
Is this your last day?
So it's about time to time out. So I'll leave you with that.
Beamer, I was at HSS last week, and they were talking about you leaving. So it's not like it's known just at home.
That's true. Yeah.
Wow.
So I might be heading back up north and working at the big house. So there's been an opportunity to take over more with the Mets and fill in their thrower, shoulder, elbow opportunity there with Dave Alchek retiring real soon. So my wife and I spent some time up there last week checking it out, or 2 weeks ago checking it out, and probably will make the move sometime before the start of next MLB season. So we'll see, but I'll keep y'all posted.
What a great announcement. Anybody else changing jobs?
No,
I'm not.
I'm not, but I think I have something that kind of.
Thanks, y'all. I'll see you later. Thanks, Winston. This is
nicely
great.
on that question, and it was one of the things that I kind of wanted to leave, especially the chiefs and the fellows that are present with. Having we've had a couple of new people, fresh out of fellowship join our practice, and it's been interesting. Me now being 5-6 years into practice, watching them go through what I was going through 3, 4, 5 years ago, giving me an opportunity on the other side of things to reflect back on that time frame. And I think one of the things that's really important, I was very grateful. I can distinctly remember both Dr. Chabra and Dr. Dacus telling me but it's really true. And it's really important to remind yourself of when you get out into practice, especially if you're going into a private practice setting, you're not going into, an extremely well established academic type practice. It takes time to build a practice. It does. We're so used to, being at UVA and training there and, training in a tertiary care hand center. It's really easy to fall into the trap of just thinking that, cases and patients just grow on trees and they just fall into your lap. And that's not how it works. And I remember my mentors telling me that, hey, it's going to be different when you get out there and it's going to take time to build a practice. And I think that's really true. And I was very grateful that I had mentors tell me that. Otherwise, I think I would be feeling a way that, a couple of my, people that have just joined the practice are feeling. You get a little squirrely. Oh, I've only got a, dozen people in clinic today. And, not me, but the people that have just joined the practice but I remember those days and I remember feeling like, oh gosh, is this ever going to be how I want it to be? And being able to reflect back on my mentor saying it's going to take some time. It takes 5 years or so to develop a mature practice. And I would reflect back on those times when I would feel a little squirrely. And I thought that was really, really helpful. And I think if you take good care of patients, and you do a good job in the operating room and you treat people well and you treat the families well, it will happen, but it will not happen overnight. And I think reminding yourself of that is really important when you're first out, to kind of get you through some of those times where you question the trajectory of your practice. It's true. It happens, but it doesn't happen overnight. I'm now, busier than I could ever be. I had to cancel a clinic just to put on, more cases because I didn't have a place to do them in a timely fashion. And that's a great problem as a surgeon to have. But, it took 5 years to get to that point. And, if you don't have that to reflect back on, like I think a couple of my junior partners are, it's easy to kind of get down in the dumps and question about whether or not you're in the right situation. But if you keep that in mind during some of those really kind of lean days early on, you're going to be more comfortable. And speaking of those lean days early on, I think there's a few things that I did that I reflect back on during that time frame that I'm really glad that I did. And it touches on a few of the things that we've also talked about. I spent that time to go meet primary care physicians in town and, introduce myself to the ER docs in town. And I also spent that time going back and looking through my billing and what's gotten paid and what hasn't gotten paid. I don't have the time to do that at all now. But early on, when you've got, one of those clinic days where you only got 10 patients, taking that time to do some of those other things is really, really valuable in developing your practice. And those are things that, I wish I had time to do now, but I don't. So doing those things early on, when you do have those lean days and you're worried about whether or not you're ever going to have a busy practice, and utilizing that time in those ways is a really efficient and an effective way to kind of build a practice early on.
Yeah,
Jeff, that's a great advice. I mean, I think I kept harping on you that it takes 5 years before you don't worry about your elective practice getting your elective schedule being full. Right. Yep. And that's true. And you've been in the same practice since day one, right? 7 years in now. If you move practices, you start all over again. Because it's not like, if you move from Alabama to DC, it's not like people will know you in DC. You're going to have to develop that practice and you start all over from day one. So, it does take time to grow. My mentor, Dave Green, said that for residency and fellowship is the ideal world when you're in training. But once you get out into the real world, it's your world and it's far from ideal. And it took him 30 years to build the San Antonio Hand Center to where he visioned and where he wanted it to be. 30 years to get it to where he wanted to be. And he was in the same practice for 30 years, right? So I think it's a constant evolution. And it's not like you, after 5 years, everything is great and you figured everything out. It's constant evolution.
On that note,
I'm
you
gonna
guys
add to what
hired-
Jeff said, if that's okay. I agree with him 100%. That's how building my practice has been like. One of the things I feel like I caught on too late was that first couple years, you're going to be seeing a lot of stuff you don't really care about as a surgeon. But I didn't realize how much that adds to my established patient population, and that, the kid I saw for Sievers when he was 12, and I was annoyed. It was like, this is stupid. I want to get cases. He comes back in a year later with a torn ACL, and they're like, you're our guy. We want you to do the surgery. So I think getting established patients as a private practice has been so important for me. Getting people in the door. I don't care what they have, tailbone pain, heel pain. It doesn't matter, because once they become loyal to you and they really like you as their doctor, they come back to you. And for kids, I see the 6-year-old with the buckle fracture, but then a few years later they grow up and they have something that's surgical and they want you to do their case. So I think that I didn't realize how important that was early on, but it definitely has shown itself now that I'm entering my 4th year. It's just building up. Every day I get more established patient, new complaints showing up in my office time, and I think that's huge.
And so do their family and friends. I mean, that's how it works. And that's why I think taking call, especially early on, and taking extra call is so important too. You fix grandma's hip, and next thing you know, son, daughter, granddaughter, all coming in to see you for, things that are a part of your elective practice. And that's just how it happens. And again, if you take good care of people and you show that you care, and you spend time with your patients, it just happens, but it doesn't happen overnight.
That's a good point. So first off, anyone hiring in this group? Some graduating chiefs now?
Yeah, anyone going, look me up.
We just hired another peds surgeon, but maybe in a couple of years we'll be
expanding.
Looking. Yeah. Any other questions? Go ahead, Dan.
I was gonna say the other thing that I think we've heard a lot is sort of this common thread of feeling a little bit isolated and overwhelmed, especially right out of practice. I think the fact that that's a common thread should give us some comfort too. Like, you really don't need to feel isolated. You don't need to feel the fact that you're going through this alone. We've all gone through this. I think even the senior faculty at UVA, they can remember back to their first few years and realize that, man, it's tough. It is hard. So, I think that it's important time to be careful about your own mental health, and, to lean on those connections that you made during residency. And that's whether it's reaching out to your classmates or, other residents or other co-fellows or mentors you had in residency or mentors you had in fellowship or your partners or whatever. Like, take some time, make sure that you're doing okay. And it's a super stressful time. And then having, throwing boards in there, it couldn't be they couldn't make it more stressful than the timeline that they put in there. But it's something that we all go through. We're trained well to do it. So give yourself a little bit of grace as you go through that process. Lean on other people, and don't be afraid to reach out, because we've all been there. We've all done it. Like Nicole, Michelle, Trent, you guys could get through it too. And it is better on the other side. It doesn't go away like Jeff said, but it does get better on the other side. So, keep on fighting the good fight. But trust the process for the people coming up in the residency. If you just UVA has it figured out. I'll say that. UVA has it figured out about how they train residents. You're gonna get good training just by even doing the bare minimum, but you put in the extra effort, man, you're going to become an excellent surgeon, and you're going to know how to take care of people. And then you trust your instincts when you're out there seeing stuff you've never seen before, but you trust those instincts, those foundations that you built. You're going to be fine. You're going to be totally fine.
That's awesome. I think the one common theme I've heard from everybody on this panel is the importance of not only your mentors, but your friends, your colleagues. And we're all in this kind of together, and all of us, it's like someone used the term isolating. It is isolating when you're by yourself, but always remember you have all of us, both people who are back at UVA, but also your classmates, the networks you create through your fellowship. So everybody's kind of going through the same kind of process. And so I think it's really important to fall in those relationships and know that you're not actually alone in this whole process. So, well, we'll wrap it up. Bobby, you have any last comments?
Yeah, don't do the bare minimum, as was mentioned by Dr. Hess, because your stress in your first few years of practice will go through the roof if you did the bare minimum. So, Dr. Hess did not do the bare minimum, I can assure you that. I think that we're going through some faculty who are going through board collections right now, and that level of stress is probably the most you'll ever experience, those of you who are going through it. So lean on your mentors for that. Dan flew into Charlottesville, and I tortured him. I made him and Pat O'Callahan, our one of our fellows, they know each other from Michigan. I made them sit in 95-degree heat on my porch, sweating like crazy. I didn't give them any water, and I made them present their boards to me because I wanted them to suffer, because that's what taking the boards is like. Trust me, I'm a board examiner. It is the worst experience in the world. But don't you agree, Dan? It was awful taking the boards.
Maybe wear a trash bag. I lost 20 pounds. Oh, it's brutal.
But I mean, it's a stressful time point, but you have us to get you through. So I just saw Michelle in New York, and I told her, don't forget to come back and visit and help us prepare you for your boards. So
thank you guys so much. You guys are great. And then I'm sure that, the residents could reach out. I mean, I have all your emails for anybody for their follow-up questions. Okay. So appreciate you guys. Come visit us in Charlottesville. We'll have an alumni meeting here soon.
Next spring. A year from now. Yep.
Very good. Thanks, guys.
Thank
Enjoy
you
your
all.
day.
Thank you all.
Good seeing y'all.
Thank you all.
Thanks, everyone.